Colles fracture is a common fracture of the radius, most commonly caused by a fall onto an outstretched hand with the wrist extended and the forearm pronated. This video looks at the clinical anatomy of the forearm and wrist, providing a sound anatomical background in order to reach a correct diagnosis. Your learning objectives are to understand the clinical anatomy and mechanisms of Colles fracture, to know the management and treatment options for this fracture, understand the possible complications of Colles fracture and how to anticipate and avoid them. Colles fracture is an extra-articular transverse fracture through the distal radius 2 to 3 centimeters from its articular surface. The typical patient is an elderly postmenopausal woman experiencing cortical thinning and osteoporosis, but it can occur at any age. Fracture forces acting on the radius may also be transmitted to the ulnar styloid process via the triangular fibrocartilage, occasionally causing an avulsion fracture. In a Colles fracture, the distal fragment is normally displaced dorsally and may be impacted. Sometimes the distal fragment may also deviate laterally. Often there is dorsal angulation of the radial articular surface, which when viewed from the side may give rise to the classical dinner fork deformity. Colles fracture should not be confused with Smith's fracture, which is a mirror image of the Colles fracture, and is often called a reverse Colles fracture. This fracture is caused by a fall onto an outstretched hand with the wrist flexed. This causes the distal fracture fragments to displace ventrally, giving rise to the garden spade deformity. Most Colles fractures can be managed conservatively, with closed reduction to restore the bones to an anatomical position and fitting of a cast for approximately 6 weeks. Originally made of plaster of Paris, the more modern casts made of fiberglass come in many bright colors. Sometimes general anesthesia, regional anesthesia such as a brachial plexus block or a Beers block, or even local anesthesia such as a hematoma block is used. Occasionally where the articular surface is involved, or in an open or comminuted fracture, surgical reduction and fixation may be required. Potential complications include median nerve injury resulting from pressure from bone or soft tissue swelling. This may present as an acute carpal tunnel syndrome. Delayed rupture of the extensor pollicis longus tendon due to attrition of the tendon by bony fragments. Persisting deformity of the wrist leading to impaired function of the limb. Delayed union, malunion, or non-union of the fracture. Reflex sympathetic dystrophy or Sudeck's atrophy, where the hand and wrist remain warm, tender, and painful due to sympathetic nervous system dysfunction. In summary, Colles fractures are common in an increasing geriatric population, and they require correct reduction and immobilization in order to avoid long-term disability.